Welcome to this launch event for the Health Foundation's COVID-19 Impact Inquiry. I'm Claire Moriarty, and as well as chairing the session today, I'll be providing strategic advice throughout the inquiry and chairing the expert advisory panel that we've set up. It's really exciting to have so many of you join us today to hear about the work we've done so far and what we're planning to do over the next few months. With COVID-19 still dominating the news and our lives, and set to do so for months to come, this feels like an important moment to launch this inquiry. The virus and the measures taken in response have had huge impacts that have fallen unevenly across society. We already have evidence of existing inequalities being amplified and of groups being newly disadvantaged by what they've needed to do or been unable to do as a result of the pandemic. It's really important that we understand the pandemic's legacy and its impact on health inequalities, in order to give everyone the opportunity to live a healthy life in the future. The inquiry aims to advance that by creating a robust evidence base and joining up research being done in different parts of the UK from different perspectives. In this webinar, we'll hear from Tim Elwell-Sutton on the evidence we've seen so far of the pandemic's impact on the nation's health and on the wider determinants of health. Then we'll hear from Meranisha Suleiman, who is the senior researcher heading the Secretariat for the inquiry. She will be highlighting the areas of focus for the inquiry, how it will be carried out, what we hope it will achieve, and how you can contribute to it over the coming months. And finally, we're delighted to be joined by Yvonne Coghill, a member of our expert advisory panel. Yvonne will be talking to us about the pandemic's impact on Black and minority ethnic groups and sharing experiences of Black and minority ethnic health and care workers. Before we start, I'd just like to share some housekeeping information with you all. First of all, this is a Zoom webinar, so you may have noticed that your cameras and microphones are disabled. This will remain the case throughout the event. If you do have any technical issues, please use the Q&A function to let us know, and our tech team will do their best to help you out. We are recording this webinar, so if you do miss any of it, you'll be able to catch up at another time. Later in the webinar, there will be a Q&A session, during which we'll tackle a selection of your questions. Thank you to those who've already submitted a question. And if you haven't done so, we'll be taking some questions live too. So please use the Q&A function on your screen to send in your questions. You can also vote on questions, which will give us a sense of what's uppermost in people's minds. So please do make use of that. And finally, for those of you wanting to join the conversation on Twitter, we'll be using the hashtag COVID-19 Impact Inquiry. Please do share your thoughts on the areas we'll cover during the webinar and any reflections you have on the inquiry. So to get us started, I'm going to hand over to Tim Elwell-Sutton, who will be talking about what we know so far. Tim, over to you.
Thank you very much, Claire. I am going to share some slides with you all, and I'm going to just say a little bit about the sort of starting knowledge that we have. The pandemic, as I'm sure everyone is aware, has had an enormous impact on the nation's health, but it hasn't affected everybody equally, and there has been a huge amount of rapid research to try and understand the impacts that it's already happening, that's already happened. And I think, you know, we've been trying to keep up with that and to collate it in a series of publications. So we have a series of blog called Emerging Findings, but there's a huge amount that has been coming out very quickly. I'm just going to scratch the surface here with some of the main things. So where I'm going to start is just with where we were, I think, when the pandemic hit us, because that's really important. That we didn't all come into this sort of from the same starting position, health and health inequalities going into the pandemic, because I think it's important for us to understand that where we start has a huge impact on where we end up with this. So this is a very big picture stuff. If you look at mortality rates across it, this is just England and Wales, but similar trends across the UK, you'll see that they had been declining for many years. And actually that trend line on the left-hand side, you could extend back probably another 50 years and you'd see something similar. But we saw a very marked change in the way that health was improving in around 2011. And it slowed very dramatically. Now this happened in many high income countries, but it was faster and sharper in the UK and the US. And so we came into this pandemic with our nation's health not improving as much as we have historically expected it to. And on the right-hand side there of the slide is the Marmot Review, which was published in February this year, Marmot Review 10 years on, and there's much more in there about this trend if you want to know more. But of course, it's not just about how we were doing overall as a nation. Not everybody was doing as well as some others in society. So this is looking at life expectancy and crucially healthy life expectancy, which is the blue part of that bar, across different deciles of deprivation. And you can see that if you focus on the healthy life expectancy, in the most deprived areas, healthy life expectancy was just 52 years compared to 70 in the wealthiest parts of the country. Now that has a profound impact on people's health, on the economy, on communities, and on families. And I just want to talk about that also in terms of health resilience. So those points on the right-hand side of my slide there, 1 in 4 adults coming into this pandemic had 2 or more long-term health conditions. So that's over 14 million people just in England. But we also know that in the most deprived areas, that comes much earlier in people's lives, about age 61 compared to age 71 for people to have 2 or more long-term health conditions. And we know that those conditions put people at much higher risk of a bad outcome if they do catch COVID. But it's not just about our physiological resilience coming into the pandemic. I think it's also important to think about our economic and social resilience, because this hasn't just been a health event, it has been an economic and a social crisis as well. So coming into it, we have general poverty rates of over 20% of people living under the official poverty measure, which is less than 60% of median income. If you think about the financial crisis which happened in around 2008, there was large unemployment then. We've actually done pretty well at creating employment since then. So employment levels coming into the pandemic were actually quite high. But what we hadn't done so well was create good quality work or improve incomes. And that's why the poverty rates have stayed pretty flat in recent years. But it's also really important to know that people, those low-income families particularly, had very, very few savings coming in. So 65% of low-income families had no savings or below £1,500 savings. Now that's absolutely critical to understand the impact the pandemic is having at a time when people are being furloughed, when people are losing their jobs, and their normal lives are being disrupted. And we'd also, of course, seen major cuts to public services over the last 10 years. So that's where we started. Now, what do we know about what COVID has done since it arrived earlier in the year? This is just looking at the first peak of the pandemic in terms of excess deaths. And the zero line there is the sort of average at this time of year over the past 5 years, I think, in previous years. So you can see that at the peak there, the red line is the UK line. At the peak, more than twice as many people as normal were dying. And we did much worse on that than most other similar countries other than Spain. We don't know yet what will happen in the second peak, but we do know that this has been a massive shock to the nation's health. But of course, some people affected far more than others. This is the distribution of COVID deaths by age. And of course, it's very highly concentrated in older people. But also, if you look at it by deprivation again, you can see a huge gap. And this sort of follows a similar gradient, I would say, to the life expectancy data that I showed you earlier on. In the most deprived areas, people have been more than twice as likely to die of COVID than those living in the least deprived areas. So it's not just a massive health shock overall, it's potentially exacerbating existing inequalities. This is looking at COVID deaths by occupation group, and it's a really interesting pattern here and a slightly different pattern. At the bottom, managers, directors, senior officials, so more affluent professions certainly have lower rates. But if you look in the middle there, People working in caring, leisure industries and other service occupations also have very high rates, and that's likely to be to do with the fact that they were going out to work when many of us were locked down and so were more exposed to the virus. And we also know that particular groups within the population have been more badly affected than others. This is the really stark findings by ethnicity that people of Black ethnicity are more than 4 times as likely to have died from COVID. So it's having a huge impact on some people more than others. We also know that, I've talked a lot about physical health, but we also know that the mental health impacts have been large and they have been unevenly distributed. So overall, using a standardized measure of mental health, rates across the population have declined by more than 8% since pre-COVID levels. But if you look at disabled people, 46% of them report that their mental health has got worse compared to just 18% in non-disabled people. And it's important to think about the ways in which multiple identities have an effect here. So if you're both young and a health worker, both groups we know at higher risk of mental health impacts, 71% of those people say that their mental health has got worse during COVID. That's what's been happening during the pandemic. What do we know about the long-term impacts? Well, of course, the answer is we don't know yet, but I think we can make some very good educated guesses about what the long-term effects might be, particularly thinking about the social and economic impacts of the pandemic as a whole. We know that people's social and economic conditions are some of the strongest drivers of health in the long term. And we also know, looking at this chart, that those who came into it in the weakest socioeconomic position have been affected worst by it. So patterns of employment loss and furloughing by income suggest that the burden of this is going to fall disproportionately on those who already had lower incomes coming into it. So it risks exacerbating health inequalities further, I would say. I'm going to say something about access to healthcare services. Now, this is accident and emergency use during the first peak of the pandemic, and you can see that in every age group, they've declined massively. Now, A&E, we tend to think of as a short-term measure, but what the point I'm trying to make here is that there was a huge impact on the healthcare system. This is one of the easiest measures of it. Lots of people who would normally be using the healthcare system for very good reason did not, particularly during lockdown, and there have been huge knock-on disruptions. So I think we really need to look out for what the long-term effects, medium and long-term effects of the disruption to the healthcare system will be. And particularly those red bars there, children particularly had their healthcare disrupted, it looks like, from these data. So I think we just don't know yet what impact that will have, but that's the kind of thing that I hope we will learn more about during the inquiry. Sort of final point I want to make here is that I've talked about lots of ways in which certain groups of people have been affected more than others by the pandemic. Of course, we all have multiple identities and may fit into more than one of those groups, and it's important to think about the cumulative impact of them. So this is a slide about the impact on young people, particularly, not children, but sort of 12 to 24 age group. We know that their mental health has declined more than others. We know that they're twice as likely to have lost their job or been furloughed. And we know they're less likely during lockdown to have private indoor space or a garden or access to public green space. And we know that they report their relationships being damaged more than people in other age groups. And so when you put all of those things together, it's really important to take a rounded picture of the impact that the pandemic has had on people in that way. Are there any positive things that we can build on from the pandemic? I think there are a few. So we know that particularly during lockdown, volunteering, mutual aid, community spirit came to the fore, and there are a huge number of anecdotal reports of that. And is that something that we can build on and use for the future? statutory sick pay and universal credit were boosted by the government during the pandemic, can we recognise that actually those were always a problem and that they need to be sustained into the future? So I know many people are arguing for universal credit rises to continue. Recognition of health inequalities. To me, I've been working on health inequalities for a very long time. I've never known it have as much profile or as much understanding, I think, in the public domain as it does now. So can we capitalise on that attention that it's getting to build something for the future? Is there an opportunity to build back the economy better? I'm just using this to plug a report that we published last week about how economic development strategies can be used to improve health. But I think there are real opportunities to do things differently in future. And if we're trying to rebuild our economy, can we make sure that we do it in a way that benefits everybody and that protects and improves health rather than exacerbating health inequalities? So I'm going to stop there. Thank you for listening. We're going to move on now to a short video, which has a number of members of our expert advisory panel speaking about why they think this inquiry is important and why they're involved in it. Thank you.
The impact of COVID on health is evident at so many different levels. There is the direct effect of the virus directly on health, and then there is the way that the various measures that are having to be taken in order to protect people from the virus are impacting on factors like employment, like education, which in turn indirectly affect people's health. The pandemic is intensifying and amplifying existing areas of inequalities.
COVID-19 is a massive external shock to the social system. External shocks expose the underlying inequalities in society and amplify them. We published a report with the support of the Health Foundation in February 2020, showing that the slowdown in improvement in life expectancy in the UK was more marked than in any other rich country except Iceland and the United States. And then the pandemic happened, and the Office for National Statistics looked at excess mortality. And the excess mortality in England was higher than in Scotland and other parts of the UK, and higher than in any other European country.
One of the striking things that has emerged from the coronavirus pandemic is how it has impacted differentially on different segments of the population, how it has reinforced existing health inequalities and the appearance of those existing health inequalities. People living in poorer areas have a much higher risk than people living in richer areas. This is almost certainly a result of individual differences in socioeconomic fortunes. And ethnic minority people, of course, this most striking finding that we've seen is that ethnic minority people are at much greater risk of mortality from COVID-19 than the majority population.
It's vital to consider the wider determinants of health when we think about the coronavirus pandemic, because this wasn't just a health crisis. It was also an economic crisis and a social crisis. It had effects on every single part of our lives. Surely we can make this an opportunity for change.
We need to tailor our responses to the coronavirus pandemic in order to ensure that they do not amplify and rather reduce inequalities. It's crucially important that we have an inquiry that focuses on the question of inequality in relation to COVID-19, an inquiry that looks at health inequalities both in the immediate context of COVID-19, but also in the longer term. So how the responses to COVID-19 may be amplifying health inequalities, and at the same time looks at those fundamental drivers that are producing these health inequalities, both in relation to COVID-19 and in relation to the consequences of COVID-19.
I think the results of this inquiry will enable us to try and make this a turning point for health inequality.
What this inquiry does that I think can add value to all of that other work, we are going to try and understand the different pieces of work that are going on, to join them up, to connect them, to be able to see the bigger picture, to extract some really important themes, and to provide a solid evidence base that people can draw on in starting to answer these questions, both about what the short and medium term recovery policies should be, and also understand over the longer term how we can improve people's health and tackle some of these very, very big issues of inequality. So, can I thank Tim very much for his for taking us through some of the data, and hopefully you heard from the video why we think that the inquiry is so important and some of our hopes for it. And now I'm going to ask Maranisha to take us through how we're going to turn those hopes into practice through the inquiry.
Thank you so much, Claire. Good afternoon, everyone. It's a wonderful privilege for me to join the Health Foundation to lead on the COVID impact inquiry. And what I'll be doing is sharing with you some of what we've been developing already in terms of our approach to undertaking the inquiry, how we will be taking those initial steps in the next few months, and how you can get involved in contributing to this effort. And in terms of what you've heard already, there has been, I'm also having problems moving through my slides. Oh, there we go. The focus of the inquiry will be twofold: to try and understand the impact of the virus itself on people's health and the health inequalities that they are experiencing, but also the impact of the policy responses that have occurred in potentially compounding some of those pre-existing health inequalities. We know that what makes us healthy is not just what contributes to our physical health in terms of an absence of disease, but all of the factors that both Claire and Tim mentioned, including economic, social, and environmental factors. As you all well recognize, the scope of this inquiry is incredibly large. And so what we want to do is distill and draw together on robust evidence to provide a place of reference for future policy. We know that there will be long-term research that will be providing insights onto the impact of the virus as well as the policy. But what this pandemic has shown is that there is a prevalence of misinformation and a plethora of evidence out there already. And so there is a need to draw all of those insights into one space. And what we'll be doing is looking at 3 timestamps in particular, which I will explain, and spotlight specific areas of inequalities that need more focused attention. You've seen some of that data already in terms of the impact that the pandemic has had on Black, Asian, and minority ethnic groups, that there is a gendered experience that's important, that men are succumbing to the virus more, but that women are suffering the social and economic consequences. Challenges faced by people living with mental health and disability are particular that we want to focus on. And one of the key issues that we want to look at in terms of the impact of the pandemic and some of the responses is around this issue of digital inclusion. Some of the opportunities that going virtual has brought has not been seen equally, particularly in aspects of education, employment. And so we do want to look at this issue of digital inclusivity and potentially the new inequalities that may have arisen as a result of the pandemic, particularly that experienced by working mothers. We're aware that there are vulnerable groups that may not necessarily have their experiences captured by some of the evidence already. And finally, what Tim mentioned in terms of all of these themes not existing in isolation, and looking in particular at evidence that reflects that intersectionality that will enable us to look at the compounding and disproportionate impact of the pandemic. We've been developing a framework to help us arrive at a method that I will talk to you about briefly. In terms of the 3 timestamps, we want to look at the pre-pandemic infrastructure that existed. What were people's experience of health and well-being prior to the pandemic that had implications for them in terms of their exposure to the virus, but also the severity that they experienced as a result of the virus and their outcomes. Related to that is this issue of the wider determinants, the economic and social circumstances, particularly deprivation, that meant that people had particular experiences in terms of their exposure and outcomes. And then within the pandemic itself, that middle timestamp of what has happened in the last few months, how has the government, how have social responses impacted people's health and health inequalities? Tim raised the issue of access to A&E services, for example. There have been many other services, particularly preventative services, such as access to vaccines, vaccinations for children, as well as access to cancer screening services and other preventative services that we want to look at and then track through what the impact of these types of policies may have in terms of the long-term implications. And so although we may not necessarily be able to say definitively what the impact will be on people's future health and health inequalities, we'll be able to use different types of data to track what the potential consequences will be. In terms of our methodology, we're hoping to use 3 steps for that. The first is to really distill the existing evidence, benefit from a lot of what's happened already, and that evidence gathering will involve looking at existing literature as well as mapping and drawing from ongoing research, both quantitative, looking at a lot of the numerical data that's coming out of the Office for National Statistics, as well as the Institute for Fiscal Studies, and work that's undergoing at the Health Foundation. And secondly, complementing that with qualitative data, narrative accounts from the different groups that we want to focus on, and also evidence that's already been collated in terms of the public experience and public opinion on their experience of the pandemic. And the aim of this part of the methodology is twofold. We want to know what's already out there, but also to understand what is missing, to try and fill some of the data gaps through in-house analysis, additional interviews and polling, and also to evidence who lies below that data line to inform future research. And we're hoping by March, we will have the evidence together to then arrive at a synthesis. So how can you get involved? So in terms of our first step of the evidence gathering, we're very keen to reach out to all of our stakeholders, everybody who's on this webinar and beyond, to feed into our call for evidence. We'll be putting that out in the next couple of weeks, so please do look out for it. And myself and the Secretariat look forward to hearing from you and your contribution to the inquiry. Thank you so much.
Thank you very much indeed, Marinisha. It's brilliant to have that all outlined. And I mean, can I particularly reiterate, we are really keen for people to get involved in the inquiry. It will be so much better with the input that all of you can bring. I'm going to hand over now to Yvonne, who's going to talk to us a bit about the experience of Black and minority ethnic groups. Yvonne.
Thank you so much, Claire, and thank you so much for inviting me to be part of this fantastic panel. It is the most important work I think we could possibly do at this time, and being asked to talk about the human cost of COVID, I think is one of the things that I probably can do reasonably well, having listened to my colleagues talk about the data and so on. So, first slide, please. I think that last week we all found and we all heard that you know, over 1 million people had died of COVID worldwide. And I think that was incredibly shocking for most of us, simply because 1 million people, that means that's 1 million people's family members, husbands, wives, sons, grandparents, and so on. So each one of those people that died has a story, and it impacts their families, their friends, their livelihoods, the whole way that they live their lives. We also heard that, you know, the President of the United States and his wife had also tested positive for COVID-19, which means that the virus, and I think we knew this back in the spring, doesn't differentiate whether you're somebody of high social standing or low social standing. It actually doesn't differentiate. And if you don't take the adequate precautions that you need to, potentially you might end up with this awful disease. And we also know that quite a few people in this country have died of COVID-19, and lots of people have tested positive. So I think that where we are at the moment, we're still in a pretty difficult place as far as COVID's concerned. It's not as if we have come through the pandemic and we're looking back and thinking, oh, goodness gracious me, we should have done this and we should have done that. We're still very much in it, and it's still very much impacting on all of our lives, as you can probably see from this webinar, because we are all mostly at home. Some of us haven't been into London for a long time, and others of us are in parts of the country where we have different restrictions in terms of lockdown up and down the country. So this is impacting every single one of us. The way we live, the way we are, the way we have been used to living our lives are completely different now to what they were 6 or 7 months ago. Next slide, please. So what we also know about COVID-19 is that it impacts on certain people and certain groups, and it impacts on people differently. And we know from the very beginning that it was impacting on men much more than it was impacting on women. It was impacting on people from Black and minority ethnic backgrounds, and I will talk a little bit more about that when the next slide comes up, thank you. And also the other people who have been impacted on by this disease. So what I want to do is to talk to you a little bit about how it's impacted on me. And these are just some of the clinicians, some of our clinicians, not all of them, that were impacted and actually have died of COVID-19. And if you look on the bottom line, the third from the left, there's an individual there called Dr. Alpha Sadhu. And Dr. Alpha Sadhu was a very close friend of mine. I've known Alpha for a very long time. And the last time I saw him was last November 2019. We went to an event together, we sat together, we laughed together. And Alpha was a very well-liked man in the NHS. He was a consultant, geriatrician. And he was very fit and he was a very healthy man. He wasn't fat, he wasn't overweight. He didn't live in a house of multiple occupancy. He was an incredibly fit and really wonderful gentleman. And when I heard that Alpha had succumbed to this disease, it was when it began to really wake me up to the fact that there was something going on for Black and ethnic minority people, because the received wisdom was that, you know, you needed to be living in a house of multiple occupancy, you needed to have comorbidities, you needed to be, you know, in a social class. And then we heard that 10 of the first people that died from COVID were doctors, and all of those doctors were from Black and ethnic minority backgrounds. And so the bells started to ring in my head, particularly about what was going on for Black and ethnic minority people and the impact on those communities. And when I began to hear, because in my role as one of the lead nurses, that not just one or two, but several Filipino nurses had succumbed to this, something was not quite right. And the piece of work that was done by the Office of National Statistics actually made me realize that there was more to this than met the eye, particularly for people from Black, Asian and minority ethnic backgrounds. Can I have the next slide, please? And what that really showed, I think, was that you were 4.2 times more likely to die of COVID and 4.3 times more likely if you were from a Black and minority ethnic background than if you were from a white background, which is quite horrendous actually. And even taking into account age and other socioeconomic factors, what we could see was that you were still 2 times more likely to die from COVID-19 if you were from a Black and minority ethnic background, and if you were from a Bangladeshi or Pakistani background, you were still 1.8 and 1.6 times more likely, males and females respectively. Now these figures are really quite scary, and they kind of like trip off the tongue, I suppose. But working in healthcare at the time, and actually working with nurses and others, I can tell you that the amount of fear that there was within the nursing and the medical workforce was phenomenal. We're not here to talk about the PPE, the equipment and protective gear issue that was going on in the NHS at the time. But what I can say is there was a lot of fear, and a lot of people were incredibly worried, not for them, just about themselves, but also about their families. And being on the front line, and we know that a lot of our Black, Asian and minority ethnic staff are on the front line, so they are exposed, were more exposed and are still more exposed to the virus than others. There was a lot of unhappiness and a lot of fear and worry about what was going on. And I can say that that has been consistent throughout the last 6 to 7 months, with people really concerned about their own health. And when you look at these figures, you can actually think to yourself, well, actually, we can understand why, because disproportionately people from Black and ethnic minority backgrounds are actually succumbing to this disease. So next slide. I think we know that there are several reasons for this, and colleagues have just been through, Tim particularly, some of the data and talked about the health inequalities that we have in our society. And we also know that in this society, people from Black, Asian and minority ethnic backgrounds, some people from Asian, Black and minority ethnic backgrounds have a much more difficult time living in white society than their white counterparts. And that's even when you look at people who have got high levels of qualifications compared to people who haven't. So one of the things that we know is that if you are from a Black, Asian and minority ethnic background, you are more likely to have be front-facing with the virus. So we know that taxi drivers, bus drivers, people who are in security, as well as hospital staff, are more likely to have to go into work and to be at work, rather than people who are in white-collar jobs who can, like myself, stay at home and protect myself. So we know all of that. We also think that, you know, some of the reasons for the people of various ethnic groups becoming sick and succumbing to COVID are some of these reasons here: comorbidities, excessive exposure, living in houses with multiple occupancy. But the thing that I pointed out earlier about Dr. Al-Fasadu and lots of other doctors and some nurses is that they actually have not been in these kind of circumstances. They don't live in those kind of circumstances. The excessive exposure, perhaps, but in terms of comorbidities, we can't always say that. Living in houses of multiple occupancy, we can't always say that. Obesity, we can't always say that. So people are trying to explain away what the reasons are for Black and ethnic minority people actually succumbing more to this disease than others. And I've had the opportunity to talk to lots of colleagues worldwide. You know, I talk a lot to a colleague of mine, Dr. David Williams in Harvard. And there has been talk about, you know, the lack of vitamin D and people not getting enough vitamin D, so their immune systems aren't as robust as other people's. There's also been talk about the fact that, you know, racism and discrimination consistently and persistently weakens your immune system as well. It has an impact on you physiologically, making you more susceptible to the virus. But we haven't been able to put our hands on exactly what the cause are. It could be all of these, it could be some of these, it could be something else. And actually, I think that, you know, this inquiry might be able to help us with some of that, because we know that people from those backgrounds tend to be in the lower socioeconomic groups, and that could be one of the reasons for some of that, as well as all of the other indicators. So I think that this is one of the things that we really do need to understand, and we need to know about this this awful disease and this illness. Now, as we are speaking today, we know that the virus is still on the rise, it's still on the increase, it's still out there, it hasn't gone away. We're going into the winter months. And I think that, you know, for us and for me particularly, it is to get to grips with and understand and know a little bit more about what we can do, not only to protect ourselves, but to protect our communities, to enable our communities to understand what it is that they need to do in order to protect themselves and their families. Because unless we get to grips with this, we're not going to be able to go back to a semblance of what we used to call a normal life. And I don't know how long this virus is going to be with us, but I do know that the human cost is enormous, and that we need to find solutions in order to help and enable us to actually live our lives better than we are doing at the moment. So thank you, Claire, and I'll hand back to you now.
Thank you very much indeed, Yvonne. That was really, really, you know, very compelling just to listen to you talking about that. We're now going to move on to the Q&A section of the webinar. I am personally massively excited that we've got 70 questions that have come in while we've been talking, as well as a lot of questions that people sent in advance. We've only got until 1:30, so we're not going to be able to get through all those questions, but they are incredibly valuable because they are all things which will give us helpful pointers as we actually go through the work of the inquiry. Can I remind you just to keep sending in the questions? Don't feel, as I say, we won't be able to get to all of them today, but they are all really valuable to us, and I can see that there are some offers of help in there, as well as questions to answer. I'm going to come on to the kind of top ranked questions that are showing up on the Q&A, but I just want to start with one that came in advance, but which has also been asked by Emma Stone as part of the live Q&A, which is about digital exclusion. And Marinisha touched on this when she was outlining what we're going to be doing in the inquiry, but it would just maybe be helpful to unpack that a little bit. And the question was, how far is digital exclusion, that's digital and health literacy, affordable access, now a serious risk to health inequalities? And I wonder if I can go to Tim first on that.
Yeah, thanks, Claire. I mean, I think it already was, but I think it is a much greater risk than it was previously. So I think, you know, so much of life has moved very rapidly online during the pandemic that I think we really do need to consider that as a significant source of health inequalities. One area which I'm aware of, and there are lots of ways you could think about this, but one area that I'm aware of is in education. So when schools were shut down, there was a lot of evidence, there's good data from the Sutton Trust, that pupils in more deprived areas were much less likely to have the right IT to be able to participate with online learning, and many of them didn't have even adequate internet access. So that's the kind of thing which there will be very immediate effects from things like access to health services, but I think you know, much longer term impacts potentially from things like the impact on education.
Great, thanks very much indeed, Tim. I'm going to go now to the question which, of all of the ones that have been asked today, is the one that people have been most interested in. I think it was 63 hands up for this one. From Mark Brooks, will the inquiry also look at increased suicide rates, as well as the recession impact, but also issues such as isolation, domestic abuse and relationship breakdown? Yvonne, I don't know if you'd be happy to get us started on that, and then I'll see if others want to come in.
I think it's a brilliant question, and I think most of us would say immediately yes to all of those, that it has had an enormous impact on people. We already know that there is increased levels of domestic abuse, We know there's increased levels of, children being in difficult and awful situations with parents who cannot cope in terms of finances and so on. And we know this all anecdotally. So I'm hoping that the inquiry will be looking at that, and people in isolation as well. Isolation is quite an interesting one, because I've been at home for the last 6 months, and my husband, who's a deputy headmaster, was at home with me for quite a substantial length of that time. And he went back to work in September, and I have been home alone since the beginning of September. And I have to say, it does impact on you being on your own all day. And I can't imagine what it would be like being alone all day, every day, with nobody to talk to, and just being socially isolated. So I can imagine that it is a huge issue, and I hope that it's one that we're going to be looking into quite closely. I'm looking at Anurisha when I'm saying that, so hopefully, yes.
Anisha, do you want just to come in on that?
Absolutely. Well, actually, Claire, I wanted to speak a little bit about both of those points. The first, Mark's question is excellent. You have raised a lot of the issues that come together when we're thinking about the mental health impact of the pandemic. So we will certainly be looking at the issue of increased suicide rates and potentially the contribution of individual factors such as isolation, as well as relationship breakdowns in potentially contributing to that, but other factors as well, such as those around economic factors, people's social, economic resilience that may be contributing to these issues. And very happy to take this conversation offline, Mark, if that would be helpful. In terms of the digital exclusion question, I just wanted to add that what we're seeing during the pandemic is an inadvertent change in the healthcare infrastructure. We know prior to the pandemic, there were particular groups that didn't access e-health or telehealth. Work done by Professor Gurch Randhawa at the University of Bedfordshire showed that people who are elderly or don't have digital literacy, don't access that sort of healthcare. We've already seen that there has been a disproportionate impact of that infrastructure change for those groups. So we will want to look at that more carefully in terms of what it will mean for our healthcare infrastructure long term if we're having to provide services virtually much longer than we anticipate.
Thank you, Manisha. And while you're there, I noticed there's a couple of questions about some of the practicalities of the inquiry. So one person was asking what the timescale is, and somebody was asking if there are going to be regular updates. Do you want just to cover those off while you're there?
Absolutely. So the timeline is that we want to be reporting by June of next year to provide the evidence base to inform medium to long-term policy around this. Claire, what was the second question?
So there's one about whether there'll be regular updates.
Absolutely, yes. So what we're going to do is, when you logged into the webinar, there was also the option to sign up for regular updates that we will be emailing to you. And if you want to have contact with us in the interim, then please do. Fantastic.
Thank you very much indeed. One of the questions that was getting quite a lot of votes earlier on was about data, and particularly the kind of it was about ethnicity data that was controlled for age, and asking whether there was also data control for socioeconomic status, etc. I think Yvonne answered some of that in her question, but I just wanted to flag that Tim has posted a link to more detailed data about that. Tim, and I wanted to come to you because one of the questions that's come up is about how the results of the inquiry can influence policy on health inequalities, and I wondered if you just like to say a little bit about that.
So I think that's an absolutely crucial question, because we want this inquiry to actually make a difference, not just be interesting to read. We've sort of limited our ambitions in it to an extent, because we're not suggesting that this inquiry will give all the answers and come out with a sort of detailed, fully fledged policy platform. But what I hope it will do is highlight the key areas which government and society need to address in rebuilding after COVID and in responding during COVID. So I think having a really deep understanding of the impact that the pandemic is having is a critical kind of first step to responding effectively, and particularly to protecting those who've been most badly affected by it. And I hope that's what we'll do, that we will provide a really strong foundation and really clear guidance about what do we need to do, what are the challenges, and what does the response need to achieve to stop our nation's health declining and to stop health inequalities exploding.
Great, thank you very much indeed. Now, another of the questions that have come in live that has got a lot of votes is David Wallace's question: how serious is the threat of long COVID? Yvonne, I don't know if you've got any thoughts about that.
I have actually, because I have, and again, it's anecdotal, but it's people who have actually been affected by COVID, and I know quite a few of people of colour who have actually, had COVID, and are actually still recovering 4, 5, 6 months later. I think people might believe that actually you have this virus and then it disappears and it's all right and you're back to normal again, and like a president that will remain nameless, you can go out and about immediately without, but for some people it does seem to linger, and I wonder who are those people and why that actually happens, and why some people are back to normal practically almost immediately. So I think there is something about long COVID that I'm not expert enough to be able to pin down and say, well, this is the reason why, and maybe it's this. So I'm hoping that'll be something that will come out of this inquiry, for sure. Great,
thank you very much indeed. I'm cracking through the questions. I'm relying on my other panelists to tell me if they particularly want to come in. There are several questions that people have asked about intersectionality, and it's certainly an issue that comes up very strongly. I mean, Yvonne, do you want to say a little bit about that, and then I will come on to Marinisha and Tim too, if he'd like to comment.
Well, for sure. And I think in my short presentation, I actually talked about the kinds of people that potentially might be more susceptible to COVID. And it isn't just one sort of person. It is, all of us carry with us lots of different, I wanted to say, groups. So, for example, if you're looking at the Equality Act, we know that we all have all sorts of different gender, ethnicity, faith, and so on and so forth. So, protected characteristics, if you will. And I don't think it's any different with this. I think that, there are some of us who are maybe a little bit bigger, some of us who are from ethnic backgrounds, some of us who might be disabled, some of us who might have mental health issues. And I think an amalgam of those things potentially might make you much more susceptible to this virus. So I think intersectionality is one of the things that we really, really do need to look at, not just, with the virus, but health inequalities generally. I think it's really important that we actually keep a close eye on that. And I think my other two colleagues will probably be able to say a little bit more, but I think it's really important.
Great, thank you. Marinisha, do you want to just say a little bit how we're planning to tackle intersectionality?
Yeah, great question. One of the things that we're keen to do as part of our evidence call out is encourage organisations, research institutions, individuals who are already doing the type of work that would help inform some of our narrative around the impact of intersectionality. So if you are doing work that's looking at, for example, the impact of the pandemic on women from minority ethnic backgrounds who are suffering mental health, and the impact of having to isolate, that's an example of evidence that we will be keen to draw on. And what we'll be doing is looking at work that's already been done by the ONS, but then also doing novel data analysis to bring some of these different variables or factors together so we can look at them more closely.
Thank you. Tim, I don't know if you wanted to add anything.
I think the only thing I'd add, Claire, is that it's an analytical problem sometimes looking at intersectionality. It makes the data difficult. But almost much more important, I think, is that the responses and policies take account of intersectionality. So I think too often we treat people in the way we set up programs and policies as a slice of what they are, and we don't see the whole of them. And I think for me, that's where actually often working at local and regional level is really important, rather than national policies, which find it very difficult to get to grips with the sort of multiple identities that people all hold. So I think it's a really important theme for how we respond to COVID, not just how we analyse it.
Great, I think that's a really, really good point. Now we're almost out of time. There was one more question that I wanted to ask from those that were submitted in advance. It's a question that could have half an hour each to reply to, but you've got less than a minute each. So the question I had, there's a sort of sub-question. It was two questions combined. One is, why haven't health inequalities exacerbated by COVID-19 been tackled effectively before the pandemic, and perhaps slightly more manageable in the time available? Is achieving health equality really realistic? So I'm going to come to each of the panelists in turn. A short answer to a huge question would be much appreciated. Tim, do you want to start on that?
Sure. I mean, for me, I think the answer to both questions is that these are choices we make as a society. We actually know what drives health inequalities. We know it's the conditions you live in, your economic situation, your environment, the social conditions you're in. So there isn't a great mystery about that. And we know that if we have a society that is unequal, economically, socially, environmentally, then it will produce health inequalities. But we also know that we make choices about these things, and it's about how we structure our economies, it's about how we organize society. I don't expect in my lifetime that I will see an absolute end to health inequality, if I'm honest, but I do know that there are countries which do much better than we do. And I would really like us to choose as a society to prioritize reducing inequality, because it is doable. It's just about the choices we make.
Fantastic, thank you. Yvonne?
Yeah, I couldn't agree with Tim more. And somebody asked me recently if I thought that race inequality would be resolved within the next 10 years, and I said no, and people were horrified, but I said no. I think that health inequalities are so much bigger and broader than just race on its own. So I don't think in my lifetime I'm going to see it become any different to what it is. In fact, Sir Michael Marmot's work actually said it's getting worse, and I think as human beings there's something about us where we have to look down and up to get our own feeling of worth and well-being and all the rest of it. And I think that, for us all to be the same is going to take some doing. And I don't know that we're even in that place of discussing that yet. So I think it's a really very difficult one. We can do better though. We can definitely do better.
Yeah, absolutely. And Marinisha?
Three things to say about that, Claire, which is that we know that more equal societies are better societies in terms of measures of well-being. And there's been challenges before, because often our approaches to inequalities has been disparate. It hasn't been a systems approach looking at all the different factors together. And as was pointed out in the video, that maybe this is the point at which we can address this. Richard Horton in The Lancet highlighted that this isn't a pandemic, it's a syndemic. It's not just about the health impacts and the impacts of the virus, but all of the social and economic issues. And I think this is our opportunity to spotlight that. I'm an optimistic person, so I think collectively we can do something.
That's brilliant, and both a kind of far-reaching and an optimistic note to end on. Unfortunately, we will have to stop here. We're coming to the end of the webinar. I'd like to thank our brilliant panellists, Yvonne, Marinisha and Tim, for taking part and contributing to what I've certainly found a really interesting discussion. I'd also like to thank everyone who's joined us today for being part of this journey with us, and for your fantastic questions, which, as I say, we've got over 100 that we haven't been able to answer in the time available today, but we will certainly use them all as part of understanding what is important to people in this inquiry. So I hope you found this webinar useful, that it's given you some ideas about the work we're doing and how you can get involved. As I said earlier, the webinar has been recorded, so it'll be available to watch on demand. We'll let you know when it's ready to view. We look forward to sharing findings of the inquiry, and as Marinusha mentioned, we will be coming out with a call for evidence shortly. So finally, please do go to our website, sign up for inquiry updates using the link in the chat box. Thank you very much, and goodbye.